seizures do not always happen alone. For many people, seizures are part of a bigger pattern. These patterns are called epilepsy syndromes. A syndrome helps explain when seizures start, what types occur, what the EEG looks like, and how the brain develops over time. Understanding a syndrome does not change who someone is, but it can help guide treatment, answer questions, and plan for the future. In this video, we will explore common epilepsy syndromes in a clear and simple way, because knowledge brings clarity, and clarity brings confidence. Our next destination takes us to the very beginning of life. This is self-limited neonatal epilepsy, a rare epilepsy syndrome that begins during the first days of life. Unlike many severe neonatal epilepsy syndromes, self-limited neonatal epilepsy typically has an excellent prognosis and is considered a benign epilepsy of the newborn period. Seizures most often begin between 2 and 7 days after birth. The most common seizure type is a brief tonic seizure, which causes a sudden stiffening of the body. Focal seizures can also occur and may involve one side of the body or specific movements that reflect activity beginning in one area of the brain. Many infants with this syndrome are otherwise healthy and show a normal neurological examination between seizures. A family history of neonatal seizures is common, and some cases are linked to genetic variants that affect the brain's ion channels and electrical signaling. The EEG provides important clues. Unlike developmental and epileptic encephalopathies, such as Ohtahara syndrome, the EEG background is usually normal or near normal. Brief focal sharp waves or transient abnormalities may be seen, but the brain's overall electrical activity remains relatively well organized. This normal background EEG is one of the reasons the prognosis is so different from more severe neonatal epilepsy syndromes. Most seizures improve within weeks or months of life, and many children go on to have normal development. Some infants may require temporary treatment with anti-seizure medications, while others improve with little or no long-term therapy. The most important lesson in this chapter is that not every neonatal seizure disorder carries the same outlook. For these tiny explorers, the journey often begins early, but the future is usually bright. Our next stop takes us to one of the earliest epilepsy syndromes seen in life. This is Ohtahara syndrome, also known as early infantile epileptic encephalopathy. Ohtahara syndrome is a rare and severe form of epilepsy that begins during infancy, often within the first weeks or months of life. The syndrome is characterized by frequent seizures and significant disruption of normal brain development. Most children develop symptoms within the first 3 months of life, and many present during the first 10 days after birth. Several seizure types can occur, but tonic seizures are the most common. These seizures cause sudden stiffening of the body and may occur many times throughout the day and night. Some children may also experience focal seizures, generalized tonic-clonic seizures, infantile spasms, or myoclonic seizures. One of the most important clues comes from the EEG. Ohtahara syndrome has a distinctive pattern called burst suppression. During burst suppression, periods of high-voltage electrical activity alternate with periods of very low brain activity. This creates a repeating pattern of bursts followed by suppression. This EEG finding is considered a hallmark of the syndrome and plays an important role in making the diagnosis. Ohtahara syndrome is often associated with underlying genetic conditions or structural abnormalities of the brain. Because seizures begin so early in development, affected children frequently experience significant developmental challenges as they grow. Although treatment may include anti-seizure medications, corticosteroids, vigabatrin, or, in select cases, surgery, seizures can be difficult to control. Ohtahara syndrome is not simply a seizure disorder. It is a developmental and epileptic encephalopathy that affects both brain function and development. Understanding the seizures, recognizing the EEG pattern, and identifying the underlying cause help guide care and support for families.
Our next destination brings us to one of the most important epilepsy syndromes of infancy. This is West syndrome. What is it? West syndrome is a developmental and epileptic encephalopathy that begins during infancy and affects brain development. It is characterized by a combination of infantile spasms, developmental concerns, and a distinctive EEG pattern. Seizure types. The hallmark seizure type is the infantile spasm. These spasms are brief, usually lasting only 1 to 2 seconds, but they often occur in clusters. A child may suddenly bend forward, bring the arms inward, stiffen the body, or extend the arms and legs. Because each movement is so brief, infantile spasms can sometimes be mistaken for a startle reflex or normal infant behavior. Demographics. West syndrome most commonly begins between 3 and 12 months of age, during a critical period of brain development. Many children first show symptoms within the first year of life, often as clusters of spasms occurring when waking from sleep. Classification. West syndrome is classified as a developmental and epileptic encephalopathy. One of the most important clues comes from the EEG. Children with West syndrome often show hypsarrhythmia, a chaotic pattern of high-voltage slow waves mixed with multifocal spikes and sharp waves. This EEG finding is a key feature of the syndrome and helps support the diagnosis. Treatment. Early treatment is extremely important. Common therapies include ACTH, vigabatrin, and corticosteroids such as prednisolone. The goal of treatment is to reduce spasms, improve EEG activity, and support the best possible developmental outcome. While every child's journey is unique, early recognition and prompt treatment can make a meaningful difference.
Our next destination takes us to one of the most recognized genetic epilepsy syndromes of childhood. Dravet syndrome is classified as a developmental and epileptic encephalopathy. This means that seizures and abnormal brain activity can affect development, learning, behavior, and cognition over time. In most cases, Dravet syndrome is associated with a change in the SCN1A gene, which affects the brain's sodium channels and electrical signaling. The first seizure is often a prolonged febrile seizure, frequently triggered by fever or illness. As children grow, additional seizure types may develop, including myoclonic seizures, tonic-clonic seizures, focal seizures, and absence seizures. Many individuals experience multiple seizure types throughout life. Dravet syndrome usually begins during infancy, most often before 1 year of age. It commonly appears in infants who were previously healthy and developing normally. Early seizures are often associated with fever, vaccinations that produce fever, illness, overheating, or other stressors. Treatment often includes medications such as valproate, stiripentol, and fenfluramine. Additional treatments may include specialized diets, rescue medications, and ongoing neurological care. Managing seizure triggers and maintaining consistent sleep are also important parts of treatment. Dravet syndrome is generally considered a lifelong condition. Seizures often continue into adolescence and adulthood, and developmental, cognitive, speech, and behavioral challenges may occur. However, advances in research, treatment options, and supportive therapies continue to improve quality of life and long-term outcomes. Every journey has challenges, but knowledge, treatment, and support help light the path forward.
Our next destination takes us to a rare neurological condition known as Sturge-Weber syndrome. Sturge-Weber syndrome is a neurocutaneous disorder that affects both the brain and the skin. It is often recognized by a facial port wine stain, particularly when it involves the forehead or eyelid. The diagnosis is supported by brain imaging, which may reveal leptomeningeal angiomas and characteristic tram-track calcifications. These findings help identify the underlying vascular abnormalities associated with the syndrome. Seizures are a common feature of Sturge-Weber syndrome. Most individuals experience focal seizures, meaning the seizure begins in one area of the brain. Depending on the affected region, seizures may involve movement, sensation, vision, or language. In some cases, focal seizures can spread and become generalized.
The EEG often shows focal slowing and epileptiform discharges over the affected hemisphere, providing important clues about where seizures originate. Because Sturge-Weber syndrome affects brain development, some individuals may experience developmental delays or intellectual disability. Other complications can include hemiparesis, which is weakness on one side of the body, behavioral or learning difficulties, and an increased risk of glaucoma. The severity of these challenges varies from person to person. Treatment options. Treatment focuses on seizure control and management of associated neurological and eye complications. Anti-seizure medications are commonly used as first-line therapy. In severe drug-resistant cases, surgical options such as hemispherectomy may be considered. Regular ophthalmology care is also important for monitoring and treating glaucoma. Outcomes can vary widely. Some individuals achieve good seizure control and continue to make developmental progress, while others face lifelong neurological challenges. Our next destination takes us to Angelman syndrome. Seizures are common in Angelman syndrome and often begin during early childhood. Several seizure types may occur, including myoclonic seizures, atypical absence seizures, generalized tonic-clonic seizures, and atonic seizures. Although seizures can be frequent during childhood, many individuals experience improvement as they grow older. The EEG often provides important clues to the diagnosis. Characteristic findings may include high-amplitude, slow spike wave activity and rhythmic slowing patterns. These EEG features can be seen even when a seizure is not occurring and help support the diagnosis of Angelman syndrome. Treatment focuses on both seizure management and developmental support. Anti-seizure medications such as valproate, clobazam, and sometimes ethosuximide may be used depending on the seizure type. Physical therapy, speech therapy, occupational therapy, and behavioral interventions are also important parts of care. Angelman syndrome is a genetic neurodevelopmental disorder most commonly associated with changes involving the UBE3A gene. Symptoms are often recognized between 6 and 12 months of age. Common clinical features include developmental delay, limited speech, difficulties with balance and coordination, and an unsteady gait. Many individuals have a happy, excitable demeanor with frequent smiling, laughter, and strong social engagement. Angelman syndrome is a lifelong condition, but many individuals continue to make developmental progress throughout life. Seizures often improve with age, and supportive therapies can help maximize communication, independence, and quality of life. Our next destination takes us to Rett syndrome. Rett syndrome is a rare genetic neurological and developmental disorder that affects the way the brain develops. It is most commonly caused by a mutation in the MECP2 gene and primarily affects females. During the first several months of life, many children appear to develop normally. Over time, they may gradually lose previously learned skills, including speech, purposeful hand use, and certain motor abilities. The EEG also changes as the disorder progresses. During early infancy, the EEG may appear normal. As Rett syndrome develops, the EEG often becomes abnormal and may show generalized slowing, epileptiform discharges, and other electrical abnormalities that become more noticeable with age. Some individuals with Rett syndrome develop epilepsy. Several seizure types may occur, including focal seizures, generalized tonic-clonic seizures, absence seizures, and myoclonic seizures. However, not every person with Rett syndrome develops seizures. The prognosis varies depending on the severity of symptoms. Many individuals experience lifelong challenges, including intellectual disability, motor impairment, and communication difficulties. Treatment focuses on improving quality of life and maximizing function. Anti-seizure medications may be used when epilepsy is present. Physical therapy, occupational therapy, and speech therapy can help support mobility, communication, and daily activities. Nutritional support and management of associated medical conditions are also important parts of care. The goals of care include improving quality of life, maximizing independence, supporting communication, reducing discomfort, and providing support for families. Research continues to advance our understanding of Rett syndrome, and awareness continues to grow. New treatments and therapies are being explored to improve outcomes and quality of life. Our next destination takes us to febrile infection-related epilepsy syndrome, also known as FENDER'S. FENDER'S usually begins after a febrile illness in a previously healthy child. What starts as a fever can quickly change when severe seizures develop. These seizures often begin focally but may progress to prolonged seizures and status epilepticus. The impact of FENDER'S can extend beyond the initial illness. Some children develop ongoing epilepsy, cognitive difficulties, behavioral challenges, and long-term neurological complications. The exact cause remains unknown. Researchers believe FENDER'S may involve an abnormal immune response to an infection in genetically susceptible individuals, leading to severe inflammation and persistent seizure activity. Treatment requires a multidisciplinary approach. Common therapies include the ketogenic diet, immune-modulating treatments such as IVIG, targeted therapies such as anakinra, and anti-seizure medications used to control status epilepticus and ongoing seizures. The key takeaway is that FENDER'S is a rare but serious condition that demands early recognition and aggressive treatment. Rapid intervention may improve outcomes and help reduce long-term complications. Although the road can be difficult, advances in research, treatment, and supportive care continue to provide hope for affected children and families. BEX stands for benign epilepsy with centrotemporal spikes. It is one of the most common focal epilepsy syndromes seen in children. It is called benign because most children outgrow it as they get older, and it usually does not cause long-term brain damage. BEX typically affects children between 4 and 12 years of age. It is slightly more common in boys than girls. Seizures usually occur at night, especially during sleep. Because of this, sleep recording during an EEG is often important for diagnosis. The seizures are focal and may affect the face, speech, arm, hand, or hearing. Children may experience facial twitching, tingling, trouble speaking, jerking movements, or unusual sounds. These seizures are usually brief, and recovery is often quick. The EEG shows characteristic centrotemporal spikes. These spikes are commonly seen in the C3, C4, T3, and T4 regions. BEX can run in families, but it can also occur in children with no family history of epilepsy. Both patterns are common. The outlook is excellent. Most children outgrow BEX between 12 and 16 years of age. As seizures stop, the EEG often returns to normal. The key things to remember are that BEX usually begins between ages 4 and 12. Seizures often happen during sleep. EEG spikes are seen in the centrotemporal regions, and the condition has an excellent prognosis. To help children with BEX, healthcare providers focus on obtaining a good EEG study, making an accurate diagnosis, monitoring development, treating seizures when necessary, reassuring families, and supporting a bright future. Childhood absence epilepsy, or CAE, is a common epilepsy syndrome that usually begins between 4 and 10 years of age. It is slightly more common in girls and often causes brief staring spells called absent seizures. These seizures usually last only 5 to 15 seconds. During an episode, a child may suddenly stop what they are doing and stare into space. When the seizure ends, they quickly return to normal and often do not remember what happened. Absent seizures can occur anywhere, including at school, during conversations, while playing, or even while eating. Because they are so brief, they are often mistaken for daydreaming or not paying attention. The EEG finding that helps diagnose CAE is a classic pattern called generalized 3 Hz spike and wave activity. This abnormal electrical activity involves both sides of the brain at the same time. The good news is that treatment is usually very effective. Common medications include ethosuximide, valproate, and lamotrigine. Most children eventually outgrow childhood absence epilepsy during their teenage years and go on to live healthy, successful lives. Remember, don't judge the pause. Early recognition, proper treatment, and support can lead to a bright future. Landau-Kleffner syndrome, or LKS, is a rare epilepsy syndrome that usually begins between 2 and 8 years of age. It is an acquired epileptic aphasia, meaning a child gradually loses language skills that were previously developed. It is about twice as common in males as females. One of the first signs is difficulty understanding spoken language, known as receptive aphasia. As the condition progresses, children may also lose the ability to express themselves through speech, called expressive aphasia. This language regression occurs in children who are otherwise developing normally. The EEG provides an important clue. Epileptiform activity is often most prominent during sleep, making sleep EEG studies especially helpful for diagnosis. Key features include a progressive loss of language abilities over months to years, while intelligence and overall behavior are often preserved. The main challenge is communication. Treatment focuses on reducing seizure activity and preserving language function. Common treatments may include high-dose steroids, ACTH, and anti-seizure medications such as valproate. Early treatment may improve language outcomes. The journey can be difficult, but early recognition, targeted treatment, and strong support can make a meaningful difference. Lennox-Gastaut syndrome, or LGS, is a severe childhood-onset epilepsy syndrome that typically begins between 2 and 7 years of age. Although it can be challenging to manage, understanding the condition is the first step toward providing support and improving outcomes. LGS is defined by 3 key characteristics. First, the EEG shows a generalized slow spike and wave pattern, usually between 1 and 2.5 Hz during wakefulness. Second, many children experience developmental delays or intellectual disability. Third, seizures are often difficult to control and may occur in several different forms. Children with LGS can experience multiple seizure types, including tonic seizures, atonic seizures, atypical absence seizures, and myoclonic seizures. Because seizure patterns vary from child to child, every case is unique. About half of children with LGS have an underlying neurological condition, such as a brain injury, malformation, or another neurological disorder. The syndrome can have a significant impact on daily life, leading to learning difficulties, attention problems, behavioral challenges, and the need for ongoing support at home and school. Treatment focuses on reducing seizures and improving quality of life. Management often includes multiple anti-seizure medications, ketogenic diet therapy, educational support, and regular follow-up care. While the journey with LGS can be difficult, children benefit greatly from knowledge, teamwork, support, and early intervention. Rasmussen syndrome is a rare chronic neurological disorder that affects one hemisphere of the brain. It causes inflammation that can lead to seizures, weakness, and a gradual loss of skills over time. Symptoms usually begin between 1 and 3 years of age, making it a disorder that most often starts in early childhood. The condition often begins with progressive weakness on one side of the body. An arm, leg, or even one side of the face may become affected as the disease develops. Seizures are a major feature of Rasmussen syndrome. Most are focal seizures, although some children can develop more severe seizures. including episodes of status epilepticus. Over months to years, the affected side of the brain becomes increasingly damaged. As a result, seizures may become more frequent, weakness may worsen, and children may experience difficulties with movement, speech, learning, or thinking. The EEG often shows slowing and seizure activity coming from the affected hemisphere. Over time, the affected side may develop near continuous slowing. MRI imaging can reveal progressive shrinkage or atrophy of the affected hemisphere, helping confirm the diagnosis. Treatment may include anti-seizure medications to help control seizures. In more advanced cases, surgery, such as a hemispherectomy, may be considered. Early treatment can improve quality of life and long-term outcomes. Rasmussen syndrome is a progressive disorder, but support, therapy, and medical care can make a meaningful difference. Early recognition, prompt treatment, and a strong care team help children reach their fullest potential. Remember the key takeaways. Rasmussen syndrome usually starts between 1 and 3 years of age, begins with weakness on one side, causes focal seizures, progresses over time, and requires early intervention. Most importantly, no child or family faces this journey alone.
Our next destination is a condition that can look frightening at first glance, but it is not epilepsy. This is startle syndrome, also known as hyperexplexia. Hyperexplexia is a rare neurological disorder characterized by an exaggerated startle response. A sudden sound, unexpected touch, or other surprise stimulus can trigger an immediate whole-body startle reaction. During these episodes, the body may suddenly stiffen and the person may lose balance or fall. Because the movements are abrupt and dramatic, startle syndrome is sometimes mistaken for epilepsy. However, there is an important difference. In hyperexplexia, awareness is typically preserved. The person remains conscious and often remembers the entire event. Another important clue comes from the EEG. Unlike epileptic seizures, the EEG is usually normal during these episodes. This finding helps distinguish startle syndrome from seizure disorders. Many cases are genetic and may run in families. Mutations affecting glycine signaling in the nervous system can make the startle reflex unusually strong. Symptoms often begin during infancy, although severity can vary from person to person. One unique feature is something called habituation. When the same stimulus is repeated several times, the startle response often becomes smaller. This is another clue that helps separate hyperexplexia from epilepsy. Although it may look dramatic, startle syndrome is fundamentally a disorder of the startle reflex, not a seizure disorder. Understanding the difference helps patients receive the correct diagnosis and treatment.
Juvenile myoclonic epilepsy, or JME, is a genetic generalized epilepsy syndrome that usually begins during the teenage years. Although the brain appears normal on imaging, the electrical activity of the brain is more excitable, making seizures more likely. JME most commonly begins between 12 and 18 years of age and is often seen in families. It is important to remember that JME is genetic and not the individual's fault. JME is known for a classic triad of seizure types. The most common are myoclonic jerks, which are sudden, brief muscle jerks that often occur shortly after waking up. Some individuals also experience absent seizures, which cause brief lapses in awareness. Others may have generalized tonic-clonic seizures involving loss of consciousness and whole body stiffening and shaking. These seizures are often worse in the morning, especially after sleep deprivation. Lack of sleep is one of the most common triggers. On EEG, JME is characterized by generalized 4 to 6 Hz polyspican wave discharges, a hallmark finding that helps support the diagnosis. The good news is that treatment is often very effective. Common medications include valproate and levetiracetam, along with taking medications as prescribed. Maintaining healthy habits can help reduce seizures. Common seizure triggers include sleep deprivation, stress, flashing lights, fever or illness, and alcohol use. Because of this, a daily routine that includes adequate sleep, stress management, medication adherence, and seizure tracking is important. Key clues that point to JME include onset during the teenage years, myoclonic jerks, absent seizures, generalized tonic-clonic seizures, a family history of epilepsy, and a normal MRI. Most people with JME can live full, active lives when seizures are properly managed. Progressive myoclonus epilepsies, or PMEs, are a group of rare neurological disorders in which seizures and neurological symptoms gradually worsen over time. These conditions can affect movement, thinking, coordination, and daily functioning. PMEs can involve both focal and generalized seizure types. Some seizures begin in one area of the brain, while others involve both sides of the brain. The most common seizure types include myoclonic seizures, which cause sudden brief muscle jerks, and tonic-clonic seizures, which involve loss of consciousness with stiffening and rhythmic shaking. Unfortunately, these seizures often become more frequent and difficult to control as the disease progresses. PMEs can begin at different ages, ranging from late childhood to adulthood, depending on the specific syndrome involved. Treatment focuses on reducing seizures and slowing progression when possible. Common medications include valproate, zonisamide, and levetiracetam. While treatment may not stop the disease, it can improve quality of life and help manage symptoms. Over time, many individuals experience cognitive decline, with changes in memory, thinking, coordination, and other neurological functions. Because PMEs are progressive disorders, early diagnosis, ongoing medical care, and supportive therapies are extremely important. Mesial temporal lobe epilepsy, or MTLE, is the most common type of focal epilepsy seen in adults. Seizures originate from deep structures within the temporal lobe, most commonly the hippocampus and amygdala. Other nearby structures, including the parahippocampal gyrus and entorhinal cortex, may also be involved. The symptoms of MTLE often begin with an aura. Patients may experience déjà vu, fear, a rising sensation in the stomach, or unusual smells or tastes. During the seizure, automatisms such as lip smacking, chewing, or repetitive hand movements can occur. Awareness is often impaired, and afterward, patients may experience confusion, fatigue, headache, or memory loss. In addition to seizures, some individuals develop cognitive and psychiatric comorbidities. Verbal memory difficulties are common, and anxiety, depression, or other psychiatric symptoms may occur, affecting daily life and overall quality of life. Diagnosis relies on several important clues. On EEG, temporal spikes or sharp waves may be seen between seizures. MRI often reveals mesial temporal sclerosis, characterized by hippocampal atrophy and increased signal changes within the temporal lobe. Treatment is individualized and aims to improve seizure control and quality of life. Common anti-seizure medications include carbamazepine, lamotrigine, and levetiracetam. For patients with drug-resistant epilepsy, epilepsy surgery, such as anterior temporal lobectomy or selective amygdalohippocampectomy, may be considered. Some patients may also benefit from dietary therapies, such as the ketogenic diet. The journey towards seizure control begins with recognizing the symptoms, confirming the diagnosis with EEG and MRI, and developing a personalized treatment plan. Frontal lobe epilepsy, or FLE, is a focal epilepsy syndrome that begins in the frontal lobes of the brain. It can occur in both children and adults, and is one of the more challenging epilepsy syndromes to recognize. The exact cause is not always known, but many cases are believed to have a genetic basis. Frontal lobe seizures result from abnormal electrical activity within the brain's frontal networks. The seizures themselves can look very different from one person to another. Common features include sudden motor activity, such as kicking, thrashing, pedaling movements, or unusual body posturing. Some people may experience behavioral changes, brief staring spells, unresponsiveness, or unusual vocalizations. One reason frontal lobe epilepsy can be difficult to diagnose is that the EEG may appear normal or show only subtle abnormalities. When changes are seen, they may include attenuation or muscle artifact activity over the frontal regions. Several features help distinguish frontal lobe epilepsy. Seizures are often brief, usually lasting only a few seconds to 2 minutes. They commonly occur during sleep and may involve dramatic hyperkinetic movements. Because EEG findings can be subtle, the condition is sometimes mistaken for sleep disorders, behavioral events, or other conditions. Treatment is highly individualized and often includes anti-seizure medications such as levetiracetam, clobazam, or lamotrigine. Good sleep habits, stress management, and maintaining a consistent daily routine are also important parts of seizure control. Our next adventure in neurology brings us to Deuce syndrome, also known as epilepsy with myoclonic-atonic seizures. Deuce syndrome is a rare childhood epilepsy syndrome characterized by myoclonic and myoclonic-atonic seizures. It is classified as an epileptic encephalopathy and can affect a child's development and daily life. The syndrome usually begins between 2 and 6 years of age. Most children are developing normally before the first seizures appear. One of the first seizure types seen in Deuce syndrome is the myoclonic seizure. These are sudden, brief muscle jerks that can affect the arms, head, or entire body. They often occur shortly after waking up. Children may also experience myoclonic-atonic seizures, commonly called drop attacks. During these seizures, muscle tone is suddenly lost, causing unexpected falls that may lead to injuries. The EEG commonly shows generalized spike-end wave or polyspike-end wave discharges. These characteristic findings help healthcare providers recognize and diagnose the syndrome. As the journey continues, some children may face additional challenges. Learning difficulties, attention problems, behavioral changes, and developmental delays can occur. Early recognition and support can make a significant difference. Treatment is individualized and may include anti-seizure medications, dietary therapy, such as the ketogenic diet, regular monitoring, and educational or developmental support services. The goal is to reduce seizures and improve quality of life. The good news is that many children improve with treatment and support. Early diagnosis and intervention often lead to better outcomes. Our adventure begins with Javon syndrome, a rare generalized epilepsy syndrome characterized by eyelid myoclonia, which causes brief, rapid jerking of the eyelids. Although the movements may appear simple, they are actually seizures that originate from abnormal electrical activity in the brain. Most cases begin during childhood, with seizure onset typically occurring between 6 and 8 years of age, although symptoms may start a little earlier or later in some children. The hallmark seizure is eyelid myoclonia, often accompanied by brief upward eye deviation. Many patients also have absent seizures, and some may experience generalized tonic-clonic seizures during their lifetime. Photosensitivity affects most patients, such as bright sunlight, flashing lights, video games, screens, and certain visual patterns can trigger seizures. Eye closure itself can also provoke epileptic activity in many patients. The EEG typically shows generalized spike-end wave or polyspike-end wave discharges, often activated immediately after eye closure and during photic stimulation. These findings help confirm the diagnosis and distinguish Javon syndrome from other epilepsy syndromes. The seizures can occur many times throughout the day and are sometimes mistaken for excessive blinking, tics, or daydreaming. Avoiding flashing lights and maintaining good sleep habits can also be difficult for children and families. Fortunately, treatment options are available. Broad-spectrum anti-seizure medications, such as valproate, levetiracetam, lamotrigine, and ethosuximide may help reduce seizure frequency. Managing triggers, getting adequate sleep, and limiting exposure to flashing lights are also important parts of care. As our adventure concludes, the prognosis is generally favorable when the syndrome is recognized early and treated appropriately. However, many individuals continue to have seizures into adulthood and may require long-term treatment. Early diagnosis and effective seizure management can help patients lead active and successful lives.